We'll start with the meeting now.
Yes.
A very good evening to one and all. Today, I'd like to welcome you all to this series of classes dedicated to lens and cataract called the Cataract Series. I'm Dr. Deergha Parekh, currently working as a registrar at Sankara Eye Hospital, Jaipur, and I'll be the coordinator for this session and all the upcoming sessions of the series. I'd like to welcome all the faculty members on the panel right now. Dr. J.K. Reddy, sir, who is the Technical Director at Sankara Eye Foundation and Head of Cornea and Refractive Services at Sankara Eye Hospital, Coimbatore. Dr. Nisha Ahuja, who is the Chief Medical Officer and Consultant in Cornea and Refractive Services at Sankara Eye Hospital, Anand. And Dr. Neeraj Shah, sir, who is the Chief Medical Officer and Consultant in Cornea and Refractive Services at Sankara Eye Hospital, Jaipur. Presenter for today's session is Dr. Aditya Gupta, who is currently pursuing his IOL fellowship at Sankara Eye Hospital, Jaipur. He'll be presenting today's topic, which goes by the title Current Concepts and Recent Updates in Optical Biometers. Over to you, Dr. Aditya.
Good evening, everyone. So today's topic, as said, is current concepts and recent updates in optical biometers. So I will be going through some basics as to why biometers and biometry is important. Then I will be discussing various biometers and their principles. Then I will compare and discuss some advantages over the evolving technologies. And then I will end with a note on intraoperative aberrometry. So coming to the basics. So in today's world, cataract surgery is not just a surgery, it's a refractive cataract surgery. So we want a outcome as close to E-metro. For that, we have to have a closest IOL power that is suitable for the patient. The IOL power is based on the parameters obtained from biometry, which are then put into the IOL formulas. The two vital parameters which we get from the biometry are axial length and keratometry. Other key parameters are anterior chamber depth and lens thickness and various other additional parameters. So in 1974, Dr. Hoffers first utilized the ultrasonic biometry to obtain the axial length. Then in 1999, there was a big advancement with the upcoming of IOL Master, which is the first optical biometer. So as we know, the advantages of optical biometry are over the ultrasound are it is non-contact, precise, accurate, less time consuming, and then it includes the retinal thickness in the axial length, and it measures the visual axial length in comparison to anatomical axial length, which is given by the ultrasonic biometry. So then over the period of time, there have been advancements in the technologies and various biometers have come up in the market. So the gold standard which we considered in the today's era is IOL Master 700, which came up in 2015. So this is the compilation of various optical biometers based on the principle they use. So the four major principles are partial coherence interferometry, optical low coherence reflectometry, SSOCT, and SDOCT. Under PCI, there are biometers like IOL Master 500 by Zeiss, AL Scan by Nidec, Pentagam Axial by Oculus. Under OLCR, there are Lenstar LS 900 by Hagstreet, Aladdin by Topcon, Galilei G6 by Zymer. Under SSOCT, we have IOLmaster 700 by Zeiss, Enterion and iStar 900 by Hagstreet, Argus by Movu, and OA 2000 by Tommy. And recent to this ad is SDOCT based, which is Vemos AXL by CSO. So keeping it simple, as discussed, we have two vital parameters, axial length and keratometry. So I would say these are the technologies which utilize, these are the technologies which gives us the axial length. And various biometers also utilize this technology to give various other parameters like ACD, lens thickness, and others. So coming on to the keratometry, uh, these can be either biometers integrate either reflection based like Placido disc or LED rings, or it can be slit imaging like SSOCT or Schlenfleck imaging. The advantage of reflection based is that uh, they have a precise anterior corneal measurements, but they lack or they have a limit on posterior corneal readings, and they don't give the corneal anatomy. While on the other hand, these are provided by the slit imagings, but the limit is that they lack the precision because eye movement can result in motion artifacts. Some of the biometers utilize both of these techniques, like Galilei G6. It utilizes both Placido disc and Schlepfling imaging. Same way, IOL Master 700 and Argos, they utilize LED rings for anterior cornea and SSOCD for posterior cornea. So, in this table, I have compared the three most popular biometers, that is the IOL Master 500, Lenstar LS 900, and IOL Master 700. So, as discussed, the principle of IOL Master 500 is PCI based, that is partial coherence interferometry. Lenstar LS is optical low coherence reflectometry, and IOL Master 700 is swept source OCT. So PCI uses a wavelength of 718 nanometer, and it utilizes modified Michelson interferometer. While Lenstar LS in OLCR uses a wavelength of 820 nanometer, whereas SSOCT utilizes 1055 nanometer wavelength. So we say as the wavelength increases, there is an increase in depth and better axial length readings. The added advantage of IOL Master 700 is that it images along the entire eyeball length. So the axial lengths are based on group refractive index. This I would be discussing a bit later. Coming on to the K readings, all of these three utilizes for anterior LED rings. IOL Master 500 measures 6 points at 2.5 mm zone. Lenstar LS 32 points at 1.65 and 2.3 mm zone, while IOL Master 700 18 points in three regions in a hexagonal pattern. So the advantages of Lenstar LS 900 over IOL Master 500 are that it measures more precise K reading, and it measures additional parameters like lens thickness, retinal thickness, pupil size, and centricity. So it is incorporated with more IOL formulas and more recent formulas. Uh, the advantages of IOL Master 700 over Lenstar and IOL Master 500 are that it measures total K. It utilizes telecentric keratometry for anterior cornea and SSOCT for posterior cornea. So it incorporates Barrett true K formulas also, which helps in our toric planning and others. Coming on to other advantages, as we know that it images and views along the entire eyeball length. So it can help in letting us know about the lens tilt and the poor fixation if the fovea is not focused. So there are various studies among various biometers. So this is the study between Lenstar LS 900 and IOL Master 700 and others also comparing these two biometers. So this was to compare the IOL power predictions. So they noticed that there was no clinically relevant differences were detected between the biometers in terms of their measurements and IOL power predictions. But they said that as IOL Master 700 utilizes SSOCT technology, it was more efficient in obtaining axial lengths in cases of dense cataract or longer axial lengths. So some brief about other biometers. So Antirion by Hagstreet. It is a purely SSOCT based biometer launched in 2018. It uses even a higher wavelength of 1300 nanometer. It acts as an anterior segment analyzer with a full size measurement of the cornea and anterior eye segment. So why I am calling it as a purely SSOCT based, because it utilizes this technology for both axial length and keratometry. There is no classical keratometry is implemented. So, in various studies, Andirion showed a good agreement for the majority of parameters with IOL Masters 700 in measuring ocular biometry, except for the some variation in the keratometry. Coming on to Argus, this is also an SSOCT based biometer launched in 2015. It utilizes a wavelength of 1060 nanometer. So how is it unique? It its uniquity is the measurement of segmented axial length using a precise refractive index for each segment of the eye, so-called sum of segments, meaning that it measures the length of each segment depending upon its uh, refractive index. Like for cornea, it will measure based on its refractive index, then ACD based on its refractive index. As compared to comprehensive refractive index, as stated earlier, which it is utilized by IOL Master 500, Lens Star 900, and IOL Master 700, which utilizes group refractive index, that is a mean, to calculate the axial length. However, in general, optical biometers Ergos and IOL Master 700 shows excellent agreement in measured biometric data. Segmental refractive index technology used by Ergos caused differences in anterior chamber depths. So there was slightly higher anterior chamber depth values in Argos. However, there was no significant difference in obtaining the IOL power for the patient or outcome. It also has enhanced retinal visualization ERV mode, which allows for signal amplification in the retinal area when measuring denser cataracts. Coming on to the latest VMOS AXL by CSO, it is based on SDOCT. So there have been studies which also states that this system provides consistent measures of anatomical parameters, being most of them interchangeable with those provided by the SSOCT based gold standards. However, similar to Argos, here again longer ACD values were obtained. That was attributed to lower resolution of the SDOCT system compared to the SSOCT. Coming on to the intraoperative wavefront aberrometry. So its aim is to take a phakic or pseudophakic refractive measurements on the eye that is being operated in the operating room, providing real-time intraoperative refractive data. So there are two systems based on this technology: optical refractive analysis by WaveTech Visions and HOLOS by Clarity. So what are the advantages and disadvantages of this intraoperative aberrometry? So as we know, the aim is to reduce residual refractive error by refracting the aphakic eye. Uh, it takes into account posterior corneal astigmatism, which is particularly advantageous for patients who have previously undergone refractive surgery, which renders conventional biometry methods less predictable. Also, as it takes a phakic refraction, it is helpful in patients who have a denser cataract or PSC where correct biometric readings are difficult. It is useful for planning toric IOLs. Pre-operative biometers uh, it can be accurate, but they ignore three elements that are potential source of errors, like posterior corneal astigmatism, SIA, surgically induced astigmatism, and tilting or head misalignment during pre-operative testings. And it can also tailor in making arcuate and LRIs on table. So, what are the disadvantages? The supine position of the patient, which is not physiological, causes a shift in spherical equivalent of minus 0.37 diopter and significant cyclotorsion. The lid speculum can be responsible for significant changes in cylindrical power and axis. ACD may vary greatly during the surgery. For example, if we form too tighter a globe, or if we form too softer a globe, either we are filling anterior chamber with BSS or viscoelastic. So it can change the refractive error and refractive index and lead to variable anterior chamber depth. Also, patient's eye movements are a potential source of error. So to conclude, across various studies, IL Master 700 is considered gold standard. It is as they have given high accuracy, repeatability, and reproducibility. Comparing the devices, there may be significant difference between them, statically significant difference between them. However, depending upon the particular parameter and its use, they may be they may still be interchangeable because the clinical impact may be negligible. Thank you everyone for patience listening.
Thanks a lot, Dr. Aditya, for this wonderful presentation. Over to the faculty members on our panel for their opinion and any additional points.
So, hello everyone. So, very nice presentation, Dr. Aditya. I think with the discussion, it is clear that SSOCT based biometers are much reliable as they have a tunable laser and a swept wavelength. So, it can have a deeper penetration, faster scanning, and so it can avoid any error which occurs during the positioning of the patient. But the only problem with those is the high cost. But I think if long term we see in cases of post refractive surgeries, keratoconus, irregular corneas, dense cataracts, I think these SS based or the OCT, OCT based biometers are much reliable. I think JK sir will be a better person to guide us on this.
JK sir, can you share your experience on with Antirion sir?
Sir, are we audible? I don't think so.
I think there's some technical glitch at JK sir's end. Anyways, we'll wait for him to get back. Until then, we can continue with our discussion. So, Dr. Aditya, can you describe as to, sir, we were talking about swept source OCT. and wanted your inputs on your experience with the Anterion.
The issues now is before the optical biometers came, we are of the opinion that the axial length measurements we are going very wrong with ultrasound measurements. So that is the main source of error in IOL power calculation, apart from formulas. Formulas are there, but apart formulas were not given that great importance. That's given some importance, and they evolved formulas, over a period of time. And the main source of error in the data, in the measurements is considered is the axial length measurements. So when we are doing, not the new generation, not even maybe in your time also, every conference you go at, the first thing they tell is how to make exact measurements of axial length, whatever the care you have to take it. But after the step source, after the optical biometers introduced, that error has come down largely. It became disappeared. So because we got two Antirian and Tomy before, I will must find that wherever you measure it, unless there is a mature cataract or the patient is having esotropia, exotropia, eccentric fixation, or not able to understand well. Otherwise, all readings are exact to 0.1 millimeter in all these instruments. The main then still we are having the problem with the hemetropia. Still, you do whatever you do it, still 5 to 10% and landing up in hemetropia. So where is the source of error now? You look at the data, whatever data we are getting. For example, axial length we cannot repeat it because once you put IOL, then even you put PMMA lens or hydrophobic or whatever you select in the formula, the measurements it gives actually the measurements always is changing. It is not giving the exact measurement what is pre-operative. It's supposed to give. But now the source of error, main error in data is captometry. Whatever you do it, you do it 5 times, you repeat it. At least not in every patient. Our error in the IOL power calculation is roughly around 10%. In 10% of the patients, it is more than 0.75 or 1 diopter plus or minus. Remaining all, they fall within the one. So same thing is coming. For example, if you take a automated captometry or a manual captometry or a topographer, same mission you repeat also in 5% of the patients, it is coming different readings in almost 5%. In 10%, between the missions, there is a large difference. So which one you have to believe is becoming a big question. But among all of these measurements, so now so far the people are not, the companies are worried only in developing an instrument for accurate, super accurate action length. So that almost they succeeded with the swap source. Most of the machine I will master 700, 500 is not that great, but it's good. Unless you got a PSC, then is a problem. Dense PSC is a problem. Otherwise, simple cases, it gives very good. Mature cataracts, it cannot give. But with step source, that problem is solved. I get in Tomy one reading, same reading I get in Anterion. There is no difference. The difference between Tomy and Anterion is in the K reading, action, cartometry, and axis of cartometry. So what happens is, even little bit tear film here and there is dry. Then plasto-based, diode-based. Diode-based means IOL Master 700, they launched initially with the diode-based, 2 rows of its diode, 3 rows. Now they are giving attachment for topography, small attachment, 700. And same lens star also, they are giving topography attachment, they are finding. Whereas Tomy comes with the topography and anterior comes with the topography. They are not captometry readings with diodes. So they are matching very well. But still, we are having a difference between the two is mainly in the captometry. Tomy always is giving a exaggerated K reading. Whether they intentionally put that or it is error, we are not able to understand. If Tomy shows 2 diopter astigmatism, anterior shows somewhere around 1.6, almost 20% difference is there. Is there most of the patients, most if not all, most of the patients, 10 to 15% Tomy is showing exaggerated astigmatism. So when it comes to the corrections, against the rule astigmatism, it is better. We will correct because always we know against the rule astigmatism we are in trouble. The IOL Master 700 is they take anti-reading either with the diode based what he has shown in the presentation, or the new one is with the plastic, a small Humphrey cone they put it. The plastic disc, just like Tommy, it takes the K readings. Then it measures the OCT measures the pachymetry, and the posterior corneal astigmatism is generated, and total posterior corneal power is calculated. The Barrett Universal 2K is exclusively for IOL Master 700 for total corneal power. A lot of people they are started using that. How accurate, I don't know. Because if I use, there is a lot of difference is coming sometimes. If I use some scans, I get it from outside. IOL Master 700 using Barrett Universal 2 TK. 2K, TK means a true captometry. With that, the power calculation, axis of toric lens placement, all are different. With that, when I compare with Anterion, because Anterion also got a total corneal power readings. It will also give anterior posterior captometry readings. But it is not, they are not still incorporated. They are not paid the Barrett, or maybe 700 has taken exclusively from the Barrett the rights. So they are only getting that printout. The Anterion so far not able to give that printout. Anterion working with Dami and Gatinel for another formula. He is developing a AI based some other formula for IOL powers and toric powers. So these are the differences we saw. As far as if there is some little bit dry spot is there, and small corneal opacity, or we put the drops, or there is a tear pool, or there is a narrow palpable fissure, these things, then the captometry with the plasto base or with the AK is grossly abnormal in a dry eye, or not a very severe dry eye, mild dry eye with SPK or keratinized epithelium, or you have a little bit climatic droplet keratopathy in one corner or one side. All these are giving very bizarre K powers in reflective method based, either plasma or LED based. In those cases, anterior K reading is very robust because it doesn't depend on the reflections. It depends on the structure of the cornea. OCT based, because it is a source based readings, elevation map. It doesn't depend upon the reflectivity or the front surface of the or tear film or front surface. Whereas plasto based or dias based, they are totally dependent on the anterior corneal surface. So if the anterior corneal surface is not reflective, then we will put a teardrops. And but you have to wipe off them thoroughly, ask them to blink, then only we can take a good reading. So this is the main difference. Actual length measurement, no problem. There are some complaints about myopic power not coming very well, 25, 20, but they got that minus 15, some adjustment is there. Some number you have to add. This patient is minus 15, you add it, it is giving very accurately.
Yeah, one thing earlier, once you had said that the original IL master, which was devised, the axle length was benchmarked against USG.
Yes,
So,
that's how they benchmark is they don't benchmark based on the patients. Okay, they test it. Even they came when they first IVL must 500 is total flop in India. So they modified the acquisition method of axial length. They did a lot of things, and when they came, they asked even our hospital. They came. I don't know whether you are not at the time. Non-paying section, we gave them 200, 500. Every day he was doing 200, 300 patients and measuring the axial length like that. That is clinical testing. Before that, how the test is, they have a standard calibration PMMA block. That PMMA block, refractive index, they will add. In ultrasound, PMMA ultrasound value, they will add. Some value will be there. Then they measure. And they calibrate 500 against the ultrasound. Now all machines are calibrating against the 500.
Okay.
Even if you develop a new one tomorrow,
Hmm.
you have to calibrate against one gold standard. If IOL master in a normal patient gives 26 millimeters of axial length, your machine also should give 26.
So theoretically, if there is any error transferred from ultrasound to IL master, it will transfer to your machine.
But it is a standardized
Theoretically.
now. That bug will be there because what they are telling is all these IOL formulas, they develop based on the data, based on the old data, except for the ultra new formulas which are coming. Only optical, exclusively optical. Nobody says my pharma is exclusively optical. So everybody says either you put optical or ultrasound. Or
Hmm.
now only difference they are doing is they are giving a two color. If somebody comes exclusively my formula only for optical biometry, my formula is for true corneal power, then it becomes a separate product. That is theoretically, scientifically correct product based on
Hmm.
the each layer they ray tracing they do it right from the cornea, pachymetry, every layer. For example, you are having anterior, now right now
Hmm.
you are having Jaipur
No, we have 500.
500,
Hmm.
500.
But a couple of
If
other units like Varanasi, Hyderabad,
yeah,
Coimbatore, these people have
so you
anterior.
do anterior normal cornea. For example, you do for yourself or somebody else. When you take the Cathometry, it gives some value. Okay, spherical aberrations, everything. Aberration plays a great role in people, and spherical aberration plays a great role in the final eyeball power. So, for example, when you use ray tracing formulas, Oslo, you can do it eyeball power calculation in that. A little bit, they have to do right a little bit programming. So initially we do it that for one or two cases with the help of our friends who are designing, optical designers. We did for some 10, 15 years back, we did for post-myopic cases. At that time, 2K concept is not there. Even concept was there, but there is no machines to measure so accurately. But it comes very nicely. But it will ask for what is the spherical aberration, what is the pupil size. Even spherical aberration, a negative or positive, some value you have to give it. And we have to give the pupil size. So if the pupil size is 4 millimeter, the IOL power is different. If the pupil size is 2 millimeter, the IOL power is different. And then it will ask for what is the IOL spherical aberration, is positive, negative, or you have to enter aspheric, zero asphericity. All this data you have to enter. For example, a patient, a new lenses like eye hands or Swiss probe, which are having a positive spherical aberration in the center and negative spherical aberration in the periphery, they are still tricky. That value is entering and generating a exact theoretical power calculation for the IOL. So these are the main now. So it becomes more complex. In Oculix also, they will ask for pupil size. In Oculix, there is a separate software, Oculix, which they are, I think, some companies, Antian is giving, but you have to pay, I think, Oculix. In that, they add Oculix. That is one of the, is from Germany. They are doing very well. You have to enter the pupil size, which pupil you want. So you have to select somewhere around 3 millimeters, very small too. If it is a young person, around 5 millimeters, like that. So the
Any
problem now
experience
is the
on
cathometry. Problem now is the cathometry.
any experience with Argos? That is also available.
Argos also another problem. The Argos is from Japan, so they are the first people who developed the swab source based the main swab source which everyone is using in their machines to measure the axial length. So they are the ones which are supplying to most of the companies, web source for measuring these particular readings, maybe except Antidia, all of that they are. But their problem is what I didn't like in Argos when I saw first time. I don't know now what they are doing is Still, the captometry is based on the LED. One LED, one area, there is a dry spot. It is a reflectivity. It's not that great. You are collecting some 10, 20 points and you are assessing the KRD. You don't know it is a coma. You don't know it is a. They say the formulas are like that. For example, in topography, in anatomy, if you see that if there is a pterygium, here it will be very flat and it will be very steep and it will show 6 diopters. And you know that that's actually it won't be 6 diopters. It is exaggerating because of the flattening by the pterygium. But in Argos, you don't get like that. You don't get any map of topography. You just see the K value.
Okay.
That is
So
a
without the
problem.
map, the K values can be misleading.
Yeah, and without topography, if the astigmatism K values are. But I personally were seeing this almost for 20, 30 years. I think the topography values based on as long as you want to take the maps based on the reflectivity method, either with the diodes or with the placidos, we cannot go forward. It should be a non-reflectivity like um, uh, something like anterior or the now even the Atlas they are trying to do. But that is a combined. Again, they combine both Placido and swept source pachymetry. Uh, Something like Antirion, the other guys who are there is some other company also, two, three companies, which uses only no reflectivity, only they use optical sections elevation map to measure. From that, now then, once you have that standardized, you know that now we know we get actual length in 90%, 95% very accurately. Remaining 5% we cannot go beyond becoming virtual cataract, eccentric fixation. There are so many issues with the patient. So those are the issues are another a parallel eye surface parallel to the surface of the sensor, all those things. So
Two
then
things
comes the
in.
formula.
Yes, sir, you're saying something.
Then comes the formulas. So now the formulas, for example, AI-based formulas. Some formulas they are what is that RBS formula. So anybody you
Hill
register,
RBF.
I register, huh?
Hill
Yes,
RBF.
RBF form. So anybody who registers, for example, you register, I my register, anybody registers, and we enter the data. We enter the data and it is supposed to be they think that is our data is a bug proof. That may not be true. For example, postoperative refraction, as you see in one sometimes one optometrist will give 1.5 diopters in 90 degrees cylinder patient 6.6. The other optometrist says 0.75 is reading 6.6. So if we enter that data into that, so the entire spherical equivalent calculation goes wrong and the RBF data will get corrupted.
Correct. So one thing I wanted to ask you was in this measurement principle that these people use, this different biometers. One is this group refractive index. Second is sum of segments. So any difference between whichever principle that they use, will it affect the?
See, sum of segments is more accurate, more advanced because you know what happens is still they are in the final stages. Not, I don't think they are very accurate in that measurement of refractive index because the human lens measurement of refractive index is very complex. Added to that, in a mature cataract or in a nuclear cataract, for example, you see a nuclear cataract, patient will be reading 6.9. So that means practically he is not having a, unless there is having a process of capsular cataract. Many of our patients will be reading unaided 6.12, 6.9. So that means there is no change in the refractive index. The machine doesn't know because you are putting a grade 2, grade 3, grade 4 cataract. It automatically calculates refractive index for a denser cataract. Whereas very clear lens sometimes will have a center nuclear sclerosis and 23 diopter IOL power will be having -6, -7 AR reading and spectacle correction.
Correct.
So only those cases there is a refractive index
Change.
Yeah, it has to calculate because it's only optical principle. Ultrasound doesn't matter. Ultrasound, it changes very, very little. Whereas ultrasound based on the density. Okay, these soft lenses with sclerosis, they don't change much ultrasound value. You don't need to worry about that. Only nuclear cataract, where it's very hard, the sound wave passes very fast. And 4 millimeters is okay, zero point 0.1, zero point 0.5, that is not more than that. So there comes the completely different ways. The optical works different way and ultrasound ways in a different way. So optical refractive index of each material is each area is very, very important. But the problem is the data they are getting, for example, dense cataract, you put a nuclear cataract, dense cataract, and they measure it. So what happens there? It goes wrong because the refractive index is same. Only patient is having a thin layer of opacity and his vision is less. Or the other one is the refractive index is high, but he's got a crystal clear
Mhm.
lens.
Yes.
So there the machine cannot take a decision right now. We have to take a decision, but that option they are not giving because the too many options you will get the bugs will increase. So these errors I feel they are very, very difficult to even solve, even with the long term, even with the AI, they are very, very difficult to solve.
So, but
Provided,
Another thing about ACD, that is also one variable which is affecting the
yes.
final.
Yes, Nisha asking something?
Yes, sir. I was saying ki, sir, integration with AI and SSOCT, they are at
Hmm.
least going to means like solve some of the problems. Is it like that, or it is
No,
going
not
to?
not like that. It's not that simple. One
Yes.
is yes, AI is biased and unbiased. The AI is not going to give you what is the accurate data. It is not a scientific method. It is like intuition. Last time we are talking with one guy is called mm, Michael Moser in yes, he has done a lot of work. He's a scientist on CTM in Switzerland, and he says in Sweden and this too. So when we are going in the lift in the early morning session, in the morning 8 o'clock sessions will be there in ECRS. Then I am asking him, so how you think the people are so far coming up? You see, after you do some 1,000, 2,000 cases, you put a minus 10 plus 10 lens, you know the patient is going to have a wrong reading SRK2. So if the patient comes with plus 10, automatically you subconsciously think, okay, let me go for plus 11. So if the patient goes for plus 27, 28, if they are turning to myopia in your clinic, you know these kind of patients are going for myopia. So let me put plus 25. So you don't calculate and you don't have a data also in your computer or in a Excel sheet about that. This way I'm going wrong this way. But you have subconsciously, you have that calculation. AI is like that. Yeah, with a little bit calculation. So, for example, if you are 47K and if you are having a patient 45, 46K, so what is supposed to be? Most likely it should be hypermetro, steep K. And if 47K, you got a myopic patient, like IOL power with a long action, then you will go wrong. These things AI will pick up much faster. AI will be definitely useful, especially for. Of course, now nobody is even we are not directly saying that for a the experience. I don't say experience as surgeon, experience in clinics. Someone who worked a lot in that, so they cannot outsmart even right now AI. Like Eye Foundation, their calculations are very good. They have their own method they're doing. In Sankara, we are okay, but not strong because somebody else is taking every day. Somebody else is taking readings. We are not very strong in SCAN. iPhone is there very strong, and few more hospitals I saw. They are very very strong in the the investigation team is very strong. They see something error, still they do immersion for every patient. They do immersion ultrasound, even out coming optical biometry. We don't do. We just do optical and we go ahead, whatever comes. So like that. Where there comes the AI role is where we are deviating from the normal, from the theoretically accurate. For example, this patient is theoretically 24. He should become hemetropic. If it becomes ametropic, this particular combination, AI says, okay, fine. This particular combination with 24 power, you are doing very well. But there should be a lot of data. At least previously, they say around 10,000 to 2,000 for each data AI need. Now they improved the AI program. They're saying you don't need that much data. 100, 120 is good enough for one particular power. For example, emetropia, 22 diopters power, at least 100 should be there in the 100, 150. And at the same time, you are going the wrong way. For example, everything is good, axial length is good, preoperatively same, postoperatively same. Still the patient is going -1. And the IOL is also good. We don't know. Once you implanted IOL, you don't know whether it's correct or not. The company has supplied. We assume that he is correct, company is correct. In that case also, if that like it needs some more cases, then it will compare with such a particular readings. The patient is going wrong when you put a IOL. This particular combination of axial length and if that is the situation, that it recorrects it just by a factor, like what we are doing. If a 10 comes, we will put 11. So like that, it will recorrect. If it comes to 24 and patient is going to -1, it says 23. Like that, it will recalculate the power A and give it. But there are many things you should be correct. Number one thing is the refraction. Number two is the IOL implanted. You put a 21 diopter label, but you are not sure that it's 21 or 21.25 or by mistake 20 label or 22 label. You are not explanted and you are not measured. So these are the things which can even confuse the AI.
So, sir, we can say like AI can only help with detection of the diseases like keratoconus or something, retinal or macular diseases. That will be more
No,
accurate in this than to incorporate like a
no,
actual measurement of.
nothing like that. Nothing. AI can say it is a irregular cornea. It's a grossly irregular. It cannot say it's a keratoconus. Unless you give a, for example, based on the math. If it is based on the 1 minute. Good evening. Vitlam. Now,
So one of the factors which affects basically all this is
problem is AI, how it can say it's a keratoconus ectasia. So if you took a bullous cut of the patient and take a topography, it looks like a keratoconus, irregular cornea, everything. So those values, so then it has to take a pachymetry data and say because it is a thick cornea, it is irregular, most likely it is not keratoconus. So it may be not, it's not formula based. We are not giving commands. You need to understand here. In AI, we don't give commands. So, for example, in a Clice media or Catacona screening programs, we give a command for the machine. For example, if superior K reading, you measure K reading 2 millimeters above the people and 2 millimeters below the people, or is the K max and K minimum, and you see where are these values. If these values are more than 2, more than 3, more than 4, like that, then suspect keratoconus or sure keratoconus. We will write a computer program command. In AI, we don't do like that. Just a standalone brain-like thing will be sitting there. We don't give any command to AI. We just feed all the data. In the data, this particular data is keratoconus, this particular data is not keratoconus, this particular is suspicious keratoconus. Like that, we will inform the AI. AI will read that data, then it will, because we are given. For example, if you give normal patients are all keratoconus, you keep on writing keratoconus in normal cornea or slightly irregular cornea, AI will diagnose that as a keratoconus. Just like you are teaching your student. For example, you are having a postgraduate. You keep on telling that postgraduate, little bit diabetic retinopathy, it is a peripheral diabetic retinopathy. No, there is a leak here. Then he will diagnose his life with proliferative. Same way also. It's like a student. It's like you are programming it. So that's why what is important here? The data. What the data you are giving to the AI before when you are training the module. That should be very, very accurate.
And so
So in
one
keratoconus, I don't, in topography map, it will pick up keratoconus easily. Yeah, we did that. But the problem is, you got a corneal scar due to some injury or some small injury in the center. It will be a conic cornea. It's not keratoconus. It is a post-traumatic ectasia or something we call it as, but it will say keratoconus. So instead of that, what they are telling is it becomes a commitment, legal commitment. So instead of that, they are going to classify this as a ectatic corneas, irregularly surface cornea instead of keratoconus.
So one more thing, as you said, ki the most common, like we have axial length is not a problem now. It's the keratometry. So now this keratometry, like integrating a Placido based or a Schemflug based is much better.
See, the companies are working on both things, but Scientific based, only two companies is only able to do a breakthrough. It's not that easy because, as he has rightly has projected in his presentation, why the Scientific based they are not. The Placido based is just fraction of a second, 0.2 seconds, 0.1 second. Patient fixes that, you get a reflective map. Just flash it and take it. That depends upon the camera speed. Now you have up to 1,000 frames per second cameras. You get it. Whereas shine fluke base, when it is rotating shine fluke, you need to patient steadily keep the eyes at least for 3 seconds, 4 seconds. If he moves, then it is got an algorithm. It will rematch and reposition it and redo it everything. But it's still a small. They think there is error. But in future, the cartometry will depends upon. I feel that is a shine fluke or a OCT based is the most accurate than plasma is also accurate, but we should be able to differentiate which is wrong plasma based map, which is the right plasma based map, which needs repetition, which cannot be taken into consideration. But that intelligence is not there now in biometers.
One question from the audience is there a role of A scan, I mean ultrasound A scan in this current era with optical biometers?
We are not doing, so we're thinking there is no role because we are matching very accurately with the, but some people double checking, you need two biometers, instead of that, they are using ultrasound. As I told you, an eye foundation, they are very good biometry, one of the best biometry I saw in my year, even anywhere comparable. They are still doing immersion. Every patient they are doing immersion, every patient they are doing, most of the cases they are doing immersion. Compare, double check.
Okay. And also the ACD, you were discussing about ACD.
Yeah. So the problem is ACD is, ELP is the question. It is not ACD. ELP is effective lens position post-operatively.
Ah,
So here what is the, then many things are there, few things in the ELP. One is the lens design, IOL design. Second thing is the journals. Where are the journals for that particular patient? The problem is they say they partly solved. So taking into consideration the lens thickness, ordinary lens comes in biometer. So where is the post-operatively pseudophakic lens once you insert it in the capsular bag, ELP? How do you calculate ELP? So because the lens is bulged anteriorly, lens is convex posteriorly, you remove the lens and put it. So the lens is not in the center. As posterior curvature is more than the anterior curvature. From the journals, if you take it, the anterior most part of the anterior capsule is, for example, 1.5 millimeters from the center of the lens. Posteriorly, it will be 3 millimeters, 2 millimeters. Okay. So what optical biometer measures or ultrasound measures only the distance between the epithelium to the lens, anterior lens surface, and posterior lens surface. You got three measurements here: anterior corneal measurement, posterior corneal measurement, anterior lens surface, posterior lens surface. Based on that, some calculations they are having where the ELP will be there. ELP will affect IOL power calculation, but maximum it will be 0.6 to 0.7 diopters, unless you are doing it in an ophthalmos.
Thank you so much, sir, for this valuable discussion. I'd like to thank all the faculty members. I'd like to thank all of you all for being a part of this session. With this, I'll call it a wrap. And I would like you all to be present and be a part of all the further sessions in this series. Thanks a lot, sir.
Yeah, bye.
Thank you. I've ended it. It's done.